Welcome to Topic 6, Part 3. We're going to start a discussion talking about obstructive airways disorders. Obstructive airways disorders are caused by conditions that limit expiration, leading to air trapping. It includes asthma, COPD, which is comprised of emphysema and chronic bronchitis and perhaps chronic asthma, cystic fibrosis, not to be confused with pulmonary fibrosis. Cystic fibrosis is an obstructive airways disorder, while pulmonary fibrosis, which involves scarring in the alveoli, is a restrictive disorder. And then bronchiectasis, which is kind of a secondary disorder associated with any of the above. Let's start talking about asthma. So asthma is a chronic inflammatory disease of the airways that is characterized by acute episodes of often severe but usually reversible bronchial obstruction in persons with hyperresponsive airways. The obstruction in the airways can cause wheezing, audible wheezing, particularly with a stethoscope, difficulty breathing, chest tightness, coughing, and this is often worse at night or early in the morning. These episodes are usually reversible spontaneously in some cases, or with treatment by a bronchodilator. So many patients with asthma will carry a rescue inhaler that's a beta agonist that causes bronchodilation. Asthma attacks can be triggered by stimuli that wouldn't normally cause symptoms in other people. Now, if a patient has frequent severe attacks of acute asthma, this can lead to irreversible damage in the lungs, and then that would lead to the development of chronic asthma or COPD. So let's look at the two different types of asthma. Atopic or extrinsic asthma is mediated by a type 1 hypersensitivity reaction to allergens. So pet dander, pollen, dust mites, things of those things can trigger an atopic or extrinsic asthma attack. Non-atopic or intrinsic asthma occurs without an allergic component, but it's triggered by things such as cold air, exercise, gastric reflux, tobacco. In both cases, there's a hypersensitivity reaction, and that leads to bronchial constriction, an increase in vascular permeability and inflammation, and an increase in mucus production that obstructs the airways. Extrinsic asthma usually begins in childhood or adolescence in persons with a family history of atopic allergies. There are two phases. The early phase, which develops within the first 10 to 20 minutes. We have antigen binding to IgE antibodies on sensitized mast cells, and this causes them to release chemical mediators, various cytokines, that's going to cause bronchospasm. And then we're going to have the infiltration of inflammatory cells and increase mucus secretion. And together, these things are going to limit airflow. The late response, about 4 to 8 hours after exposure to that trigger, we now have airway inflammation and increased responsiveness. So the airways are just kind of more likely, can be triggered more easily. And that can prolong the attack and lead to a cycle of exacerbations. So we get additional inflammatory cells, and these can produce epithelial cell injury. This can impair the mucociliary function, so the cilia don't beat as much, and we produce extra mucus, and then we don't clear it as well, and just kind of a heightened responsiveness of the airways. And as I mentioned before, chronic inflammation can ultimately lead to airway remodeling and chronic asthma. Non-atopic or intrinsic asthma is triggered not by allergens but rather by intrinsic factors such as respiratory infections. So, and it's thought that the epithelial damage can stimulate IgE production. Exercise, hyperventilation, cold, dry air. This loss of heat and water may trigger bronchospasm. Inhaled irritants such as tobacco smoke and strong odors can induce bronchospasm. Sulfites, like metabisulfites found in some food processing and beer and wine, can trigger this. Aspirin and other NSAIDs. Emotional factors and reproductive hormones in women. And then gastroesophageal reflux. Reflux is actually a fairly common cause of asthma. Okay, this slide details what causes the airway obstruction in asthma. So we have airway inflammation, and that's going to lead to an impaired mucociliary function, and that's going to produce excessive mucus, which is going to block the airways and lead to an airway limitation. That airway inflammation, we also have edema associated with that, and that edema is going to limit airflow. Airway inflammation also cause epithelial injury, and this is going to make the airways more responsive. Inflammatory mediators are also going to make the airways more responsive. So this can cause bronchospasm, and that will limit the airflow. So bronchospasm, edema, and mucus is going to lead to airway limitation. Okay, so let's go over some of the signs and symptoms of asthma. There's a wide range of signs and symptoms, and they can vary in severity. As I mentioned before, they're often worse at night and early in the morning. Common manifestations include like cough, dyspnea, chest tightness, wheezing, rapid and labored breathing. They have a thick and sticky mucus within the airways, tachycardia, decreased oxygen in the blood, hypoxemia. We're going to see a decreased peak flow in FEV1. We may also see a decreased FVC, but remember the FEV1 is going to be more affected than the FVC because these patients are going to have difficulty getting the air out fast. At first, the hypoxemia is going to trigger hyperventilation, and the patients will present with respiratory alkalosis. However, if the asthma attack is prolonged, then we start developing an increased residual volume and a decreased forced vital capacity, and that's due to the air trapping. Okay, so you can't get as much new air in if your residual volume is increased. Thus, you can't get as much out, so your FVC is down. We have increased use of accessory breathing muscles, severe dyspnea, and fatigue. Okay, so these patients are really working hard to maintain their ventilation. Ultimately, if the asthma attack is prolonged, that's going to lead to a decrease in alveolar ventilation. We also are going to have a mismatch of ventilation to perfusion, and this is going to result in hypoxemia and hypercapnia. Okay, so originally in the early signs we had hyperventilation that led to hypocapnia and respiratory alkalosis. But if the asthma attack is prolonged, then we get hypoxemia with hypercapnia, and this leads to respiratory acidosis. And then if it's really prolonged and we can't reverse it, this can lead to respiratory failure, and that's indicated by a decrease in responsiveness, cyanosis, decreased breath sounds, and ineffective coughing. Okay, diagnosis is made by history and physical exam, lab findings, and pulmonary function tests. One of the big things that they're going to look at is the FEV1 FVC ratio and see if that responds to bronchodilator. So I used to work at National Jewish Hospital years ago, and one of the things I did as a pulmonary function technician was patients came in and we did a series of breathing maneuvers looking at FEV1 and FVC, as well as things like residual volume and total lung capacity. And then we would give the patient a bronchodilator. We'd check their heart rate to make sure it increased 10 beats per minute. because if you remember, the albuterol is a beta-2 agonist, so it causes not only bronchodilation but an increase in heart rate. So once we got a good response to the we know that they got the medicine in, then we would test them again post-bronchodilator to see if that improved their breathing. Another thing, and this was more the definitive diagnostic test, was to do a methylcholine or other challenge. So a methylcholine is a chemical that we give in small doses through an inhaler, starting with the lowest dose, and then we check their breathing, and then we give successively higher doses, and we would look for a 20% drop in the FEV1 to FVC ratio. And then, of course, we gave the patient a bronchodilator to reverse any bronchoconstriction we might have caused. And then other challenges that we did actually were metabisulfite challenges, latex glove challenges, and so forth. So those were kind of interesting. Anyway, what I found, at least with the methylcholine challenges, there's kind of this continuum. Like some people will react at lower doses, and then they're the ones that are going to get diagnosed with asthma. But a lot of people will react, like myself, with a high dose, but the dose was so high that it wasn't considered asthma, if that makes sense. Okay, let's look at some of the medications. Quick relief medications act to reverse the bronchoconstriction during an acute attack. Beta-2 agonists, like I mentioned, that relaxes the bronchial smooth muscle and causes bronchial dilation. Can also give anticholinergic agents to reduce vagal tone, because remember, the parasympathetic nervous system causes bronchoconstriction, so we can reduce that. Systemic corticosteroids, these are not really quick release. They take more than 4 hours, but they would be given in moderate to severe exacerbations. And then long-term medications are aimed at reducing the chronic inflammation and airway hyperresponsiveness, so you're less likely to have to respond and have an attack. And these include inhaled corticosteroids, longer-acting beta-2 agonists, and a leukotriene receptor antagonist, because remember, the leukotrienes are one of those mediators involved. And then, of course, avoidance of potential environmental triggers, smoke, pet dander, dust mites, treatment if you have reflux, whatever the cause is, trying to avoid that. Okay, now we're on to chronic obstructive pulmonary disease, COPD. And this is really a group of diseases characterized by obstruction of pulmonary airflow. It's the fourth leading cause of death in the United States. The most common cause is smoking. Most patients, 85 to 90% of people with COPD, have a long history of smoking. Other causes can include occupational chemicals, dust, chronic asthma, and as well as genetics and one type of emphysema that we'll talk about. The disease is progressive and usually well progressed, though, before symptoms appear. And it's made up of two types of disorders. Emphysema, which is caused by destruction and collapse of the smaller airways, resulting in airways obstruction. So this is kind of shown here. We lose elastic fibers that hold the airways open and allows the lungs to recoil and get all the air out. And then chronic bronchitis, which is characterized by excessive mucus production in the bronchi, and chronic inflammatory changes, showing inflammation, in the small airways. Okay, I'm going to pull up a YouTube video here that I think does a pretty good description of describing these two disorders.